Welcome to the deep dive. Today we're getting into a really foundational study for, how we prevent blood clots, the CAPRIE trial.
That's right. And our source material here is that chapter on CAPRIE from the 50 landmark papers every vascular and endovascular surgeon should know. The actual paper was a randomized, blinded trial of Clopidogrel versus aspirin, published way back in '96 in the Lancet.
Okay, so our mission really is to pull out the key insights for you, the listener. What do you really need to grasp about Clopidogrel versus aspirin based on this huge trial?
Exactly. We want to make this influential study clear and understandable.
Now, antiplatelet therapy, it wasn't exactly new when CAPRIE came along, was it? I mean, the background mentions these big collaborations, antiplatelet trialists in '94.
Right, and the antithrombotic trialists later in 2002.
Yeah, and they'd already shown pretty clearly that these drugs cut the odds of vascular events by, around 20% compared to doing nothing?
Absolutely, about a 20% reduction.
Yeah.
So the principle was well established. Aspirin was definitely the go-to by the mid-90s.
There was a gap.
There was. People wanted another safe option. There was another drug, teclopidone, kind of related to clopidogrel, but it had, well, some problematic side effects.
Oh, okay.
So yeah, there was definitely an opening for something like clopidogrel.
Yeah.
And that's where CAPRIE steps in.
Right. So the big question for CAPRIE was, for patients with existing vascular disease, how does clopidogrel stack up against aspirin for preventing ischemic stroke, heart attacks, MI, or dying from a vascular cause?
That was the core question.
So how did they set up the study to find that out?
Well, it was a big one. Multi-center, randomized, so patients assigned by chance, and crucially, blinded.
Blinded meaning?
Meaning neither the patients nor their doctors knew who was getting clopidogrel and who was getting aspirin. Keeps things objective.
Got it. And they enrolled a lot of people.
Oh, yeah. Over 19,000 patients.
Yeah.
19,185 to be exact. Across 384 centers in 16 countries.
Wow.
And these patients fell into three main buckets based on their vascular issue: recent stroke, recent MI, or peripheral arterial disease, PAD.
So a good spread of conditions. What about the treatment itself? What were they given?
Pretty straightforward. It was either 75 milligrams of clopidogrel once a day or 325 milligrams of aspirin once a day.
And they followed them for a decent amount of time.
On average, about 1.63 years, which gave them a total of over 36,000 patient years of data to look at.
Huh.
So quite substantial.
Okay. Now, you mentioned something about patients stopping the drug early.
Right. That happens in big, long trials. About 21% stopped their assigned drug early for various reasons, not because they had a stroke or MI. The main analysis, called intention to treat, keeps these people in their original groups.
Why do that?
It gives you a more realistic picture, sort of like how the drugs perform in the real world, where people don't always take their medication perfectly.
Okay, makes sense. So a huge, well-designed trial. What did they find? What were the big headlines?
Okay, so the main outcome they tracked to that primary endpoint was the combination of ischemic stroke, MI, or vascular death.
Yeah.
Looking at that intention to treat analysis, there was an 8.7% relative risk reduction for the patients taking clopidogrel compared to those on aspirin.
8.7%. So a benefit for clopidogrel, but maybe not enormous?
Modest, yes, but statistically significant. It means if you treated, say, 1,000 people with clopidogrel instead of aspirin for this period, you might expect about 8 or 9 fewer of these major events.
Okay.
And if you only at the time patients were actually on the drug, the on-treatment analysis, that benefit was slightly larger, 9.4%.
And thinking about our listeners interested in vascular surgery, anything specific for them, amputations, PAD outcomes?
Yes, absolutely. They looked at a different composite endpoint, too.
Right.
Ischemic stroke, MI, amputation, or vascular death. More relevant, perhaps, for PAD patients. And using that same intention-to-treat approach, clopidogrel still showed an advantage, a 7.6% relative risk reduction compared to aspirin.
Okay, so still favoring clopidogrel slightly in that context, too. Did things look different in those specific groups they started, the stroke, MI, and PAD patients?
They really did. And this is where some of the most compelling findings emerged.
Like what?
Well, for patients who'd recently had a stroke, clopidogrel showed a 7.3% relative risk reduction for that primary endpoint, similar to the overall result.
Okay.
But for patients with peripheral arterial disease, the PAD group, the difference was much more dramatic.
How dramatic?
A 23.8% relative risk reduction favoring clopidogrel.
Wow, nearly 24%. That's substantial.
It really is. That was a standout finding. It strongly suggested clopidogrel might be particularly beneficial for PA patients who are, often at high risk for limb problems, as well as strokes and heart attacks.
Definitely noteworthy for vascular specialists. What about the heart attack group, the MI patients? You mentioned something looked a bit different there.
Yeah, that was interesting. In the group who had a recent MI when they entered the trial, clopidogrel actually seemed to perform slightly worse than aspirin, a 3.7% relative risk increase.
Worse. That seems counterintuitive.
It was unexpected. So they dug into that a bit more. They looked at all patients who had any history of an MI, recent or not.
And what did that show?
In that broader group with any prior MI, clopidogrel came out ahead again with a 7.4% relative risk reduction for the main outcome. So it seemed like maybe the timing or context of the MI mattered somehow.
Interesting nuance. Now, I saw a mention of later analysis by Pett and colleagues. Did they find anything else in the CAPRIE data?
Yes, they did a post-hoc analysis, basically looking back at the data to explore things further. They identified certain high-risk patients who seemed to get an even bigger benefit from clopidogrel.
Which patients were those?
People who'd had bypass surgery, CABG, those with more than one previous event like a stroke or MI, people with disease in multiple vascular beds like arteries in the legs and the heart, and also patients with diabetes or high cholesterol.
Right, classic high-risk markers, and the benefit was bigger for them.
Yeah, in that combined high-risk group, the relative risk reduction with clopidogrel jumped to 14.9%.
Okay, that's a much clearer advantage, almost double the overall benefit.
Exactly. And Vought's group also found something else important.
What was that?
They looked at hospitalizations. Patients on clopidogrel were significantly less likely to be readmitted to the hospital for ischemic events, things like unstable angina, TIAs or mini-strokes, worsening leg ischemia, or for bleeding problems compared to the aspirin group.
So fewer major events and fewer hospital trips for other related problems. That's quite practical.
It is. It suggests a broader benefit beyond just preventing those catastrophic endpoints.
Okay, so summing up the efficacy. Modest overall benefit, stronger in PA and high-risk groups, plus fewer rehospitalizations. What about safety? Any big worries with the clopidogrel?
Overall, the safety picture was pretty good for both drugs. No major alarms went off.
But there were some differences.
Yes, clopidogrel caused skin rash more often than aspirin.
Was that serious?
Not usually. It was severe enough to make someone stop the drug in only about 1.2% of cases, so mostly manageable.
Okay. Anything else?
Interestingly, aspirin actually caused more gastrointestinal issues. Things like GI hemorrhage and significant stomach discomfort were more common in the aspirin group.
Right. That's a well-known issue with aspirin, isn't it?
It is. And importantly, clopidogrel didn't seem to cause liver problems or the kind of severe drop in white blood cells, neutropenia, that had been a concern with that earlier drug, taclopidine.
So safe overall, maybe even better tolerated in the gut than aspirin, apart from the rash?
That seems to be the takeaway, yes.
Okay, so CAPRIE shows clopidogrel is safe, maybe slightly better overall, and definitely better for PAD patients. But aspirin didn't disappear. You said CAPRIE sort of paved the way for something else.
Exactly. Despite the benefit, clopidogrel was much more expensive back then. So CAPRIE didn't immediately lead to everyone switching from aspirin, but what it did do was establish clopidogrel as a legitimate, safe, and effective antiplatelet agent.
And that opened the door.
It opened the door to thinking, what if we use both? What if we combine clopidogrel with aspirin? That led to the whole concept and investigation of dual antiplatelet therapy, DTT.
Ah, I see. So CAPRIE was like the proof of concept for clopidogrel itself, which then allowed scientists to confidently test it in combination therapies.
Precisely. It provided that crucial foundation. Without CAPRIE showing clopidogrel was safe and had some benefit on its own, it would have been much harder to justify those big DTT trials.
Can you give us a quick rundown of some of those key DAP trials that followed CAPRIE?
Sure. Things kicked off pretty quickly in the early 2000s. You had the CRA trial in 2000.
What did CRE show?
It looked at patients with unstable angina, that's chest pain without a full heart attack. Adding clopidogrel to aspirin significantly cut their risk of cardiovascular death, MI, or stroke.
Okay, big one for cardiology.
Definitely. Then there was COMMIT. That looked at patients having an acute MI, a heart attack. Adding clopidogrel to aspirin gave a 9% relative risk reduction in death, reinfarction, or stroke. And importantly, it didn't significantly increase major bleeding.
So clear benefits in acute heart situations. What about after procedures, like putting in stents?
Right, that was the next logical step. Trials like PCI Cure and Credo looked at patients after percutaneous coronary intervention, PCI, getting stents.
And they found.
They established that continuing DAPT, usually for months, sometimes up to a year, after PCI significantly reduced major cardiovascular events compared to just aspirin alone. So DAPT became standard practice after stenting.
Okay, so DBT really took off for heart patients. Did this idea spread to other vascular areas relevant to our listeners, PAID, for instance?
It did. It took a bit longer, but yes.
Yeah.
The MIRROR trial out of Europe in 2012 looked at DAPT after peripheral interventions, like leg artery stenting or angioplasty.
What did MIRROR find?
It found that 6 months of DAPT compared to aspirin alone led to fewer repeat procedures needed on the treated artery and, interestingly, lower mortality too.
Lower mortality, that's significant.
It is. Then there was the CASPAR trial in 2010. It hinted, though maybe less definitively, that DAPT might help reduce major limb problems after bypass surgery for PAD, specifically if a prosthetic, an artificial graft was used. Didn't seem to help much with vein grafts, though.
So growing evidence for DBT in peripheral interventions, too. Where do the guidelines sit now for PAD?
Well, current Society for Vascular Surgery guidelines generally recommend at least single antiplatelet therapy, so aspirin or clopidogrel for anyone with symptomatic PAD.
Or Clopidogrel, based partly on CAPRIE's findings in PAD.
Exactly. The choice might depend on other factors, like cardiac history or bleeding risk. The guidelines also say you should consider DOT for high-risk PAD patients, provided their bleeding risk isn't too high.
And specifically after interventions, like leg stents.
While the big trial evidence is maybe less robust than for coronary stents, DAPT is very commonly recommended, often for at least a month, after infraguinal stenting stents below the groin to prevent clots forming in the stent.
Okay. What about other areas, like stents in kidney or gut arteries? Or carotid disease and stroke?
For visceral artery stenting kidney, mesenteric arteries DAPT is widely used, sort of extrapolated from the coronary data, although the specific high-level evidence is a bit thinner.
Makes sense. And carotids, stroke prevention.
For preventing a first stroke in people with carotid disease but no symptoms, the benefit of DAPT isn't really clear. But for secondary prevention, after someone has had a stroke or a TIA,
Yes.
trials like FASTER and CHANCE showed that DAPT, aspirin plus clopidogrel, used for the first few weeks or months, was better than aspirin alone at preventing another stroke.
So short-term DBT after a stroke or TIA can be beneficial.
Yes. Current guidelines often suggest clopidogrel alone might be a good long-term option for many stroke patients, but DAPT is definitely recommended in that early phase, say the first month or so, after an ischemic stroke or TIA.
And what about carotid stenting itself, that procedure?
Ah, yes. DAPT is pretty much standard of care during and after carotid artery stenting. There were trials from Italy and the UK supporting this, and the big CREST trial protocol used DAPT for at least 4 weeks post-procedure. So that's become common practice.
Okay, so it's really clear how CAPRIE, even with its, relatively modest overall finding, just cracked open the door. It validated clopidogrel,
Exactly.
which then allowed for all this investigation into DAPT, which is now used all over the vascular system.
You've got it. CAPRIE really announced clopidogrel's arrival as a reliable, effective antiplatelet agent. It fundamentally broadened how we approach vascular disease management, brain, heart, gut, legs. And now that it's generic, it's affordable and remains a cornerstone of treatment.
All right, let's try and crystallize the main takeaways from this deep dive on CAPRIE.
I think the bottom line is, CAPRIE gave us solid evidence that clopidogrel was a good alternative to aspirin. But maybe even more importantly, its real legacy was establishing clopidogrel so it could be studied with aspirin, leading to the whole era of DAPT.
Was there anything looking back at CAPRIE now that kind of surprises you or stands out?
Well, it's just fascinating that it didn't cause this immediate mass switch away from aspirin, probably because of the cost and the modest overall benefit. But indirectly, it enabled this huge expansion in treatment options through DAPT. Its impact was maybe less direct replacement, more enabling combination therapy.
Yeah, that's a great point.
And of course, you have to come back to that PAD-C subgroup finding, that really significant, nearly 24% risk reduction.
Yeah.
That was a powerful signal specifically for those patients.
Absolutely. So wrapping up our deep dive today, it really makes you wonder, given how far we've come since CAPRIE in '96, what's next? What could be the next big leap forward in stopping these vascular events?
Yeah.
And, how might personalized medicine play a bigger role? Tailoring these kinds of treatments even more precisely to the individual patient down the road, definitely something to think about.
For sure. The field keeps evolving.
Indeed. Well, thanks for joining us for this deep dive into the CAPRIE trial.